All right, good afternoon and welcome. My name is Sean Kluznik. I'm the president of the American Jail Association. I want to thank you for joining us today for what I believe will be a valuable and timely discussion. We have more than 50 participants registered for this webinar, which is pretty cool since we only popped it up a couple weeks ago, representing 15 different states. This level of interest on a topic tells me it's important. We have some very familiar names on the call. We have some friends from NCCHC on the call, which would be beneficial. Please, Fred, feel free to chime in if anything, get your attention. So this session came together pretty quickly. It started with a simple post on iConnect about a month ago. A member asked about the concept of unprivatizing their jail medical. I replied to that post, and Chief Deputy Perry Rockvam from Laramie County, Wyoming, said he'd be interested in that information too. And Dr. Malish from Arlington County, Virginia, said he'd be happy to help us out too. So today's session was born from that thread on iConnect. Don't forget, iConnect is a great place for all members to get great information. So let's be clear about this, though. This is not an anti-private medical vendor webinar. It's an information sharing session. Our goal is to connect agencies that want to explore different ways to shift away from private vendors or save money or just understand both sides. We're not promoting a single model of selling anything. We're sharing lessons, some experiences, and some practical guidance from experts who have lived through it. So we're recording sessions so we can make it available to others who cannot attend live. If possible, if you have questions, would you mind holding them to the end, and then we can have a QA at the end? I'd really appreciate it. So we're fortunate to have four total outstanding panelists today. Sheriff Keyrose from Arlington County, Virginia, just led his agency through a transition from a private medical provider to a self-operated model. His Chief Medical Officer, Dr. Richard Malish, is also here. Will offer definitely their experience and critique. My Director of Medical Services, Christine DeCaney, she came to the Hernando County Sheriff's Office in 2010 when we took over from a private vendor in general. CCA was running this jail, and we were asked to come up and be a transition team from that private model to sheriff's operated for the last 15 years. And then obviously I think everybody knows Dr. Marc Stern. He's our AJA medical advisor. We're grateful for everybody's time and like to get it kicked off. Dr. Stern?
Great. Yeah. So thank you everybody for coming, and AGA for putting this together. So I'm going to start with you, Sean and Jose, for a big picture of what's the motivation for a sheriff to want to privatize. And I know, Sean, and I'll start with you, and I know in your case it happened before you came, but you still have some of the history. What leads to it, and why do it?
So the history is, this is what I was taught. So I came from the former agency I worked at. I worked with Pasco County, which is one county south of us, and we were self-operated for everything. We didn't privatize the kitchen. We didn't privatize medical, and it was just the culture. And that sheriff at the time, or those sheriffs at the time, didn't want to, from their perspective, potentially lose control of certain aspects of the operation. I know that sometimes you hear that having a private vendor running your medical or your kitchen will potentially protect you or absolve you from any liability if something bad goes wrong in your facility. It's not true. It actually just adds a layer of people that can write checks, and if you lose a lawsuit or something bad happens. So really, it's just basically from my upbringing. Let's put it that way. I was trained under Major Mike Page. He was here for 7 years. So I was one of his lieutenants for that long, and I worked for him in my prior agency too. He just liked the idea of being able to directly have control over the employment of all those employees. I mean, that could go for the kitchen too, not just medical, and having the ability to have viable, true source intel when something's going wrong or the budget's going over or something bad happened. You want to make sure you have that open communication with your providers, basically. So that's why we did it, and that's why we haven't changed our model.
And so the follow-up to that, how much of that has turned out to be what he expected? In other words, what are the advantages at this point of not being privatized for you guys?
I think Christine could probably speak about that too. I
But
think
from
it's
an operational standpoint, it's kind of custody.
operate. We have the same boss. We have the same outlook, the same understanding of our agency's culture. So it's pretty clear. If you work for a private company, you're going to have a different mindset, most likely. Obviously, you're gonna transition to or adapt at some point on every site. But having the same ultimate boss, our sheriff is in charge of our agency, and it's his way or the highway when it comes to the right culture and getting things done the way he wants it done. So not having that bureaucracy is probably one of the biggest benefits, I would think.
Mm. So Sheriff Quiros, your set's a little bit different because your jail is separate from your patrol unit, but kind of same thing. And I know it started with you, Jose. Why did you do it, and what are the advantages that you hope for and are starting, if any, to see?
Yeah. So one, thank you for having us on here. I am a huge fan of AJA. I'm so glad that so many people tuned in. If you're new or you're a follower of AJA, you know how valuable they are to our profession. I've been with the Arlington County Sheriff's Office since 2001. I started the day before 9/11, and I'm very proud of being in this profession. I think we don't get enough credit for the work we do, not us, but our staff and all the people that make up our profession. And so I ran for sheriff in 2023, and I don't think I've ever met a sheriff that ran on keeping everything the same and just maintaining. And so I wanted to make a difference in the care that we provided the folks that are in our custody. And one of the things that I see is that I need to be more involved. And I know that sounds crazy because, you would say, don't you have enough to worry about? But the things that happen and don't happen, they don't just affect those that are incarcerated. They affect our operations, our staff, and our communities. And so at least Jose Quiros, and as while I'm sheriff, I want to own the issues and I want to be a part of the change and best practices. What are the best practices that we can implement to make a difference? And so I think I might be jumping ahead, but you got to get the buy-in from your community. And my community supports my decision to go to a county-run sheriff's office model of medical care. And so that was really step one. I know not everyone on this call is an elected official, but for me, it was getting that buy-in. We did have some in-custody deaths previous to me, even when I was running and before I became sheriff. And so I think the community was very involved and had a lot of questions. And so as it was said in the beginning of this webinar and of this talk, this is not an attack on any specific vendor, but I knew that when I became sheriff, I wanted to do something different. I will also give big kudos to the National Institute of Corrections. We've had 2 visits from NIC where they came in to evaluate what we were doing, and we found a lot of areas that had improvement could be made. And so give that report, and I know Dr. Malish is on here, my chief medical director, but that report is so valuable. It's about 25 pages long, I think, if I remember correctly, but it really identified a lot of the areas that we could improve on. And one of those is the communication. And I think that's in operations in general, but when we're talking about medical care, I'm not a doctor, I'm not a medical expert. And so it was clear to me the first step I had to make as we transitioned was to have a medical expert on my team. We rack our brains when something happens in our jails with, whether it's a suicide, a death, someone who has, COVID, all the things, because we can't decide who comes into the jail, right? We don't know who's walking into the booking and processing. And so given all of that, I wanted someone on my team that could say, hey, Sheriff, this, and this, given my medical expertise. Dr. Malish, we're very lucky to have him. He comes with 30 years of experience as a retired colonel in the U.S. Army, cardiology, internal medicine. And so, we got really lucky. We got very lucky, but we were very intentional and specific on what we were looking for. I wanted a leader. I wanted someone that could lead people. And so honestly, with Dr. Malish now on the team, he's taken this whole package and he's running with it because you can imagine it's a lot. I'm the sheriff. I am very involved. It stops with me, right? Everything that goes well, Jose gets the applause. Everything that goes wrong, Jose gets criticized. But you need to build your team. And so that's one of the things that I would say before I forget is make sure you build a strong team. I think we all know that from being in this profession, and also the buy-in from your community, whether it's a council, a board, you know, the mayor, whoever runs the decision with money. Obviously, I know Dr. Stern mentioned that. We're going to talk about that. But I have a contract with a medical vendor. And so really, I'm just transitioning positions. And I don't want to jump ahead, Dr. Stern, but yeah.
Great. You mentioned something that, Sean, we ought to highlight, which is the involvement of NIC and the Jail and Justice Support Center.
Right.
Sean, we were AJA had some involvement in creating that. Anything you want to say about that? And Connie, in the meantime, if you could find a citation for them that we could put up or put in the chat for people who want to contact the Jail and Justice Support Center, because I'm glad you mentioned that, Jose. It's quite a valuable resource. Sean, anything you want to add about them?
That resource has turned into a huge resource, and it's only getting bigger. I know we are, as an association, we're working heavily to try to continue to add on to what's already being offered. I know we've culled through thousands of policies, and we're trying to, end up with best practices to the best of our ability to, grab any example policies from across the country. A lot of those policies are medical policies, and I think I donated our medical policies for that expedition. So it's definitely an asset that if you haven't checked out, we'll make sure you get the link.
Good. So Christine, let's turn to you and get into some of the nitty gritty of conversion. So one thing, we can start somewhere else if you'd like, but why don't we start with liability? How do you? That's something that I know jails are going to or do ask about and wonder about is, all right, you had the private company and the company was responsible for all medical legal liability, malpractice, deliberate indifference. How do you make that work if you're self-operating?
So that's a good question, but as President Kluznik said, many of these private vendors, their contracts have caps and limits, so the sheriff is still liable even if they have a private vendor. Maybe it's just another cushion of addition to the lawsuit. However,
What he wants is an extra couple bodies.
We pay for our provider's malpractice, but he's very limited. He's less than 9 hours, so it's a very low rate. There's options such as that. There's options that the person that you contract with just carries their own, but that's something that a doctor has to have anyway. So it's not, he might need to get another rider on it for working in the jail, but it's really not a big obstacle, the liability part, taking it on yourself, in my opinion. It's just, as Sheriff Kiro said, it's key to have the leadership in place. And one thing that I totally agree with him on and want to add to a little bit is the community buy-in. When President Kluznik talked about the place that we worked from before, we were all self-op. And we had a whole list of community providers that, because we were a tax-supported, tax-exempt entity, they gave us Medicare rates. But when a private vendor comes in, they have a bigger network, so it might seem overwhelming because they have all these providers. But these community providers aren't as willing to give them those kind of rates because let's face it, their objective is to have a profit. So when they have that profit, they're not tax-supported, tax-exempt. These providers might not be as willing to work with them as they would when you're self-op.
Jose, any reflections on the liability question? How'd you deal with it in Arlington?
Yeah, Christine hit the nail on the head. I've experienced it, and the vendors have a cap. And so then that doesn't mean that the person isn't going to go after, the office of the sheriff or the county itself. But I wanted to touch on something else that Christine said, which is the community buy-in. One of the things that we were very intentional with was bringing in the fire department, bringing in the police department. So in my county, I don't do patrol. I run the jail, the courthouse, and we serve civil process. And so the police I have like 7 or 8, 9 different jurisdictions that are bringing arrestees in. So we're getting these folks at the table when we have these conversations about when someone comes into processing and they've been in a car accident, are we going to turn them away, or what does that look like? What are some of the things that potentially we could partner with the hospital so we don't have to make as many transports back and forth, because everyone on the call knows when you leave the jail, you leave the security of the, the facility, and that's a liability itself right there. So I mentioned, this is going to make a difference in operations, to the morale, the staff, those that are incarcerated, our community, the hospital. The hospital, honestly, when we show up, they're not like, yeah, here's the sheriff's office. They're already slammed. And so how can we partner with the hospital? And so early on, we brought Dr. Malish to the table with, or we're going to continue doing that with the hospital and with the chief medical director of the fire department, because everyone is involved. When one simple situation of an arrest, there's so many people that are involved, right? I've even brought in the public defender's office, the judges, educating. I think people are like, okay, here comes Jose with the whole medical transition conversation. But any community event I go to, I want the community to know that we are being innovative and being forward thinking with issues. We're not, we're not being reactive, we're being proactive. And I think communities appreciate that. Again, your community and what the issues are. Maybe in your community, the jail isn't a big issue. My jail holds about 600-ish inmates. Currently, I have 350, but out of 350, 240 have mental health concerns. And so it's mental health, co-occurring issues that we're dealing with. And so, yes, thank you.
One of the things that I want to add to this, and Christine, you kind of tickled it, is when you mentioned the caps. In a lot of communities, the malpractice insurance for practitioners to practice in a correctional setting is much higher than it is in the community. So a practitioner comes in with their malpractice from the community, and then they tell their carrier that, oh, by the way, I'm going to be doing some of this in the jail, may see their premiums jacked up. And that's, I think, is fearful for a lot of jails. And then when they look at their contract with the private vendor, they say, well, we don't have that problem. And I guess the answer to that is you're paying for it as the jail, one way or another. You may be paying for it when you hire a physician and they have to pay their malpractice and they have to pay thousands of dollars more. You can see it. When you have a vendor, you're paying it, you just don't see it. But one way or another, that liability is there, and it has to be paid for. So thank you, guys. All right, medical records, Christine. How do you deal with the transition from private to non-private with regard to medical records? You have some experience with that.
So that was the hardest part of our transition, and I tell other sheriffs this when I go inspect jails that are maybe changing vendors or going to a new private vendor. Be sure to retain the records, because when we took over, as President Kluznik said, Core Civic, it was CCA at the time, ran this jail, and they would not give us any electronic medical records because they were proprietary. So that was a difficult transition. All records had to be printed. We had to scan them all in, hundreds and hundreds of records, each record's so thick, and not knowing what the patient's medications were, not knowing anything, because we didn't get it till like the last minute, the twilight hour when we're transitioning. It was very difficult. So if a sheriff's out there like considering going private or considering changing private vendors, I would definitely have that ability that the records are yours, you retain them, so that you don't run into that should you ever have to change in the future for those proprietary records.
For sure, that should be, whether you're whether you're privatizing or not, that should be stated in your contract. The records are yours, and more than that, but talk about how the transition happens from the old vendor to the new vendor if you're staying. We can talk more about that if there's time. Jose, medical records, or Dr. Malish?
I think what Christine said, one of the things that came to mind is we are having, this is a mutual transition with the vendor. And so it's a relationship. And so we're being very intentional. I use that word a lot with the current vendor. They understand where we're coming from. We're open communication. This is going to happen, but it like any relationship, right? You could maybe call it a divorce, but we want this to be a smooth transition because the people that are in our care, their lives depend on this. And so we're very open with, hey, and I didn't say this, but we have the Falcon Group, we have a vendor that's helping us through the transition. So we have a plan, and it's a multi-phased plan. So we're in phase 1, phase 2, phase 3. And so everyone knows what the plan is. So no one can say, well, we didn't know about this because we didn't want to have these hiccups. There's going to be hiccups, but we want to at least be able to see this is where we're headed. These are the things along the path that we're going to encounter. And so the medical records, we have our mental health therapist that's run through the county. So how's that going to work with dentists, the medication, all the things. And I don't know if Dr. Malish, if you want to add anything about the medical records, you may have more specific.
Yeah, sure, Kiraz. With us specifically, we have the electronic medical record. It's subcontracted right now through the vendor, but our intention will be to continue to use the same record. And in the contract we have with the vendor, it does talk about transitioning both the archived records and not so much about the ongoing use, the right privilege as we move forward, but we've had communication with both the vendor, the current vendor, and the electronic health record vendor. And all those conversations have left me in a position of feeling pretty confident that we'll just be able to continue using the current electronic health record. There might come a day where we want to change the electronic health record, but that will be something for another day, for the future, because we just don't want to get too complicated early on in the transition. But again, to summarize, within our contract with the vendor, the record is well addressed. It's a subcontract, and that subcontract is the actions offered we know we can continue moving forward.
Jose, I want to go back to something that you said about the transition, because I remember early on, before you shared that with the vendor, you were a little bit nervous about that conversation. How did the first conversation? How did you have the first conversation? How did it go? How did you couch it with them?
Yeah, so we, like any relationship, there's always issues, right? And so we wanted to address some of the issues and the concerns we were having. And I say we, Jose, because again, I am the sheriff, and I take that very seriously. And I don't want to get off topic, but I never thought in a trillion years I'd be the sheriff of anything. But I care about what I do. I care about my staff. I care about the people that are under my care, and I want to do the right thing. And so given all that, we were having a couple bumps here and there. And I thought to myself, I think I can do this. At the end of the day, I don't know if there's any other sheriffs on this call, but the sheriff is always named in any lawsuit, and it says the office of sheriff, and it says your name. And so I don't like that feeling. And I know I can't help it. And Dr. Stern, we've talked about this, and a couple of other experts that I talked to, you can't prevent every single issue from happening, but I can be proactive. And so when we met with the current vendor, we said, hey, we really want to think about going this route. And I mean, it's not really up to them. I think the timing was right. We were up for to re-up the contract. And so we just said, hey, this is what we're going to go to. But before I did all that, I had conversations with my county leadership, because I didn't want to catch the county leadership off guard. I mean, that would have been a total disaster. And so I had conversations with, the powers that be that control the money in the county. And this was a big topic in my community. So I think everyone knew that, and it's something I ran on when I ran for office. And so I had talked about, making improvements in the care, and really bringing collaboration together, because I mentioned earlier, our mental health care is through the county already. And so the medical care was through the contractor. So we're trying to bring both together so we can really collaborate and provide, best practices, evidence-based care to the folks in the jail.
So
The
I
conversation
know what,
was,
yeah. No, I was going to say I know you were a little bit nervous that they might just say, well, if you want to get rid of us, we're leaving. Goodbye. Good luck on Monday.
no, right.
Did that happen? Why not?
No. I think we had a mutual respect, the conversation. Again, I think it's the way you approach it. I mean, and every situation is different, right? And so that's how I approach things. I mean, I wanted to be respectful to the vendor. I don't think a lot of the things that I talked about were a surprise to them, but we had a respectful conversation. But at the end of the day, I know it's been said, the sheriff or whoever runs the jail is the decision maker, and that was the decision I made, and that's where we were going. So
yeah, I think some people, it did work out well for you and you planned it well. I think some jails, one of the things they worry about is that what I just said, you'll tell them on Friday that you're thinking about un-privatizing, and Monday they're going to pull out. And I first of all, I think most of the vendors are reputable and not going to do that, but it's also not in their best business interest.
right.
It's not in their interest to be spiteful, because as it turned out for you and with others, it's not something you do overnight. And so the vendor remained for months while you made the transition, continuing to do their job and earn what they earn. So,
Yeah.
right. Christine, unless you have anything else on transition itself, can we switch to medication, how to pharmacy, and how you deal with that?
So there's many options, as you know, with pharmacy. You have your big correctional pharmacies like Diamond. You have local pharmacies. We put out the RFP for pharmacies, and our best option was a local pharmacy that does give us cost plus a management fee. So we pay cost for medications. Historically, our greatest cost was HIV meds. Well, several years back, we partnered with a clinic called IMG Clinic, who does HIV testing and provides us the HIV medications at no cost to us. So that was a big savings. We recently started enrolling the inmates for healthcare, and we're experiencing significant savings with that as well. So there's many options with medications and costs that you can explore, and you just need to actually, we put out RFP again because we're here 15 years now later, and a different pharmacy local had bid the contract, but I guess didn't understand the RFP, and they said that they would be billing us cost, but they didn't. So they didn't understand the RFP, and we wound up actually going back with our company that we use, our original company. And we have a great relationship with them. We get medications every day. They pick them every day except Sunday unless we need it stat. So there's advantages to using a local pharmacy. Some facilities here in Florida use just a local pharmacy. It depends on what kind of pharmacy license you have. Some use the health department. That's another opportunity. So there's many options out there.
And these pharmacies, Christine, do they provide them in the medications in bubble pack, or is this just stock for the nurses?
Mine does, yes. They're all blister packed. Yep. It's that option too. There's a Pinellas County local to us, south a couple counties. They have their own pharmacy and they do all stock. I mean all bottles. So it just depends on what works for you. We're about this a little bit more than Sheriff Kiro's in our population, and the blister packs, and that works better for us. So
Jose, Richard, anything about medications special to you guys?
Yeah, I can speak to it. So so the way our vendor works right now, they subcontract for most ancillary services. So pharmacy, lab, we already mentioned the electronic health record. And so there are subcontractors that are working those functions. And so for us, we're also using Diamond, with the vendor being sort of a go-between. So our plan, again, is not to break, is to keep as much intact as we can. So our plan is to continue the contract, eliminating the vendor as the middle control level. We'll continue with that vendor, And then in the future, we'll reassess and see whether some other configuration would be better. We do have other entities in the county that use pharmacy services. So we're looking at riders for those types of contracts, or fire department, some public health and things like that. But again, these are not the plan as we move into the transition is to keep as much intact as we can, with operational level changing from the vendor to the sheriff, and then we'll sort these other things out.
Yeah. That's a really good take-home message that I think we should post on in our minds, which is just change the things that you absolutely have to because transitions are dangerous times for patient care. And the fewer things you change, so if you want to change the EHR, the electronic health record, you want to change, if you can, leave them for later and just do the big stuff first. Good. Another option in some states, if the jail happens to be near the Department of Corrections and the Department of Corrections does its own pharmacy, is to partner with them. It's an intergovernmental relationship. You're not going to be charged, hopefully, a profit, but really just the cost plus handling. And it's the other advantage of that approach is that hopefully you have similar formularies or the same formularies so that when somebody moves between jail and prison, they're not finding that they have to change their medications because the jail was using one formulary and they were using something else. So good. Christine, back to you. Let us talk about a bunch of things related to personnel. And the first thing I'm going to pick is to talk about salaries. So the background for that is that in a lot of cities and counties, if you're the employer, you're stuck with whatever the county rate is, or for physicians or nurses or whatever kind of staff you have, and sometimes that can be getting a nurse to come into the jail is not the same as getting a nurse to come into the public health clinic. How do you deal with that?
So we had to hire everybody from what was it? Within how long do we have?
Just
Was it
over
90
yeah,
days?
just over 3 months. Just over 3 months. Yeah.
Okay. So in 90 days, they had to do all these backgrounds, get all these people hired, and what I did here, you have big networks like Maxim, places like that that do have correctional nurses. And if you're using an agency to cover vacancies, if you're not totally full, it's really not as, I mean, you're paying the agency more, but you don't have all the benefit package. So if you use open vacancies to do that, it's usually saving you money anyway. And they work in that setting, so they catch on very quick. So that's one option. But the benefits package, yes, you do not make what you make in the private sector. There's just even privatized correctional healthcare. It's usually always lower, but usually the benefits are better. Maybe retirement. I don't know. Everybody varies, but maybe your health insurance. Ours here historically, our health insurance is cheaper than the nurses that come from a hospital or come from a private correctional vendor. It's a lot cheaper. So you got to sell the big package, what you have to offer with that salary. That's really what you need to do for recruitment purposes, because the salary isn't as high. So you have to look at other ways to get people in the door, talking about benefits.
And how successful were you at the transition? How many were you able to keep the existing people that the vendor had?
Well, we only started out with, I want to say, 12 nurses, and 4 of them were from the previous vendor. So only 4, a third of them, 4 nurses came and stayed, and the rest were hired externally. A lot of them came from surrounding facilities and had that experience of correctional healthcare. Some of them did not. It just, when especially if a sheriff's going to transition, you may get people from other facilities that want to come because it's more local to them. It's not as much long as a commute. So, yeah.
Jose?
I said it's not as long as a commute. Maybe they're closer to the if a sheriff's taken over the private medical, you might get people from surrounding counties that want to come work for you because it's closer for them.
Jose?
Yes, I'll speak on two things that come to mind. One, I just want everyone to, maybe I wasn't clear, we're in the very early stages of our transition. So Dr. Malish was the first, obviously the hire I wanted to make as the leader. And then we're currently hiring for a HSA, a DON.
Health services, just for everybody, health services administrator.
Right, a director of nursing, a DON, and then 2 nurse practitioner positions. So Dr. Malish will oversee these key positions. And I feel like those are the key positions where, we'll continue building from there. Having said that, my team has been very involved with the county HR about hiring, interviews, salaries. And yeah, it's super hard because, you're asking someone to come into a facility and we're right outside of Washington, D.C. with cost of living. And so, but we're taking each situation and carefully making decisions. And again, I want to stress this. I don't think I would be successful without the buy-in of the county. The manager, I have a 5-person county board and then the county manager. These folks are very involved, not so much with the decision making, but with supporting my decisions. And so if I say, hey, I really like this person and, they're asking for this, those are things as an elected I can do. And luckily, but yeah, we're still, within a certain limit of, we can't offer trillions of dollars. But those benefit packages, at least in my county, are very beneficial. The retirement, the vacation, and we can even front load a couple things, some vacation or even parking. And where I am, you can imagine Washington, D.C. I mean, a parking space is like a bonus. And so offering these things, we can, just being creative. And again, your locality and where you are, so that you might know what would be a perk for your situation. Dr. Malish, I don't know if you have anything to add regarding.
Yeah, no, this had nothing to do with me and had everything to do with you and the team here. But it makes a lot of sense, I think, the process that Arlington County is using, and that is to hire these low density, high expertise positions first. And so the sheriff hired me, and then next we're going to hire our clinicians and our specialists, and then we're going to switch management over to potentially an agency for the tactical workers. It just makes sense that the leadership is in place, and then the next levels that come in are more and more at the worker B level. So that makes a lot of sense to me, but we potentially will use an agency, and our goal again is to retain as many of the current personnel as we can to minimize the pain of the transition. But from where I sit, and this might be the right or wrong time to talk about it, the 2 key things with a transition like this are personnel, getting the team in place and communicating. Telling the people that work for the vendor has been mentioned already, the community, informing everybody about the change, but the people aspect of it. And then we already talked about the electronic health record, which for me is the operational tactical framework of all that's done within the hospital. So focusing on the continuity of the electronic health record, again, which is the foundation of how the medical operations are conducted, and the team, I think, are the 2 most critical points.
Yeah, I want to highlight something that you said there. So we're talking about all of personnel, the salary, and everything else, kind of in one, which is fine. I think one of the questions I get often from a jail that's thinking about it is, where do I start? And I think, Jose, with your hiring of Dr. Malish, that kind of was the answer. I mean, reaching out to NIC and the joint, the Jail and Justice Support Center, but ultimately, boots on the ground, where do you start? You start with the technical expert who knows how to do the rest, and that's exactly what you should be doing. That's what you did with Dr. Malish. A couple of other options to think about is that in some communities, when sheriffs or jail commanders have gone to the county commissioners, they can get the salary ranges changed with the recognition that this is a different job. This is not a public health nurse, for example. It's not a public health physician. This is a correctional nurse, a correctional physician, and it deserves a different range that takes that into account. So that's one option. Another option that some jails use is just individual contracts. So it is privatization, but not really. It's not privatization in the sense that we think of you bring a company and they do everything. You're operating it yourself, but you find that for a particular position, you can hire a physician at the salary that the county allows, even with the addition. And so you go for a contract that allows you to hire that particular physician at a higher rate under a contract instead of under salary. So those are a couple of ways of dealing with it. We pretty much covered everything in personnel, but let me ask Christine and Jose and Richard, is there anything else in the personnel salary leadership realm, and Sean, also you, that we haven't covered before we move on?
No, I absolutely agree. And I guess when you asked me that question, I was thinking, like, because I was already in place, that was the sheriff's key thing, is hiring. I was the person hired for the transition. So you absolutely do have to hire your leadership first that's going to develop this for you. That is absolutely imperative. You have to have that in place first. And to hear that you're hiring nurse practitioners and stuff like that, that's great. We do have a contracted doctor. He's contracted through the sheriff's office, but we also have 2 nurse practitioners, which came on not transition, but after, when we realized that was probably a better thing that we could do and add to our budget. Because here in our state, and I guess everybody's different, all the personnel is part of the sheriff's budget. It's not the county. So it depends on what you have in place in your office as well.
Good.
Dr. Stern, one thing I wanted to mention, and I wanted maybe Dr. Malish to expand on it, is another key decision that we made early on was, where are people going to sit? And you know, I've been in the office of sheriff here for 24 years. And, you know, one of the things the NIC report says, you know, is taking a fresh look at things. And so Dr. Malish comes in and he's like, everybody's all over the place. So he has a fancy name for this new area. Everyone that has to do with something with medical care or mental health care, any kind of care, they're all sitting together. And so it's a bit, we're shaking it up and we're moving people around, and it's, you know, as the sheriff, I'm going to own it, and it's not very popular, but I think that is absolutely key to have everyone think of the hospital. You know, the folks aren't all over the place. You got the core, the ER, you know, everyone's in that hub. And so I don't know if Dr. Malish wants to add anything, but that's one of the big things that, because now we have to move terminals and offices, and it's not an easy thing to do, but he recognized that we were siloed and we weren't communicating. Folks have to go to the 11th floor, and everyone knows in a jail, nothing's moving fast. And so why not sit together? And so Dr. Malish, anything to add? You're muted, Dr. Malish.
Yeah, I think, thanks, Sheriff. I think it was notable to me when I first came here that there's a lot of mixing of space. And by that, I mean clinical space and administrative space. So a lot of, you know, the providers or the nurses would both do their administrative work and see patients in the same area. And so, you know, I'm a child of patient-centered medical home, primary care, that type of thing, and separating spaces. And so, you know, the first thought was to pull the providers out of the clinical area and give them administrative space and free up that clinical area so that anybody could use it. So that was just an efficiency measure. But then the sheriff also mentioned that you know, mental health is huge. We all know it. I'm a veteran of the Army, so I've worked in the medical system there, and mental health and physical health, or whatever you want to call it. We look at it all on the same. We look at it all together. So if I'm the provider, or if I'm the physician, you know, responsible for a large unit of soldiers or whatnot, their mental health concerns are directly under me, and there's no silos. And I know that's not unusual. The same holds true for the jail. However, the leadership was different. So as the sheriff mentioned, he has you know, he's taking over responsibility, accountability, and leadership of the medical, but the mental health team is under the Department of Health Services and the Community Services Board. And they maintain their leadership connection there for all the reasons you can imagine, the continuity of care, the larger system overlay there. But we were all separated throughout the jail, and I said, well, you know, my pedigree is to have all of this unified as a multidisciplinary team for all the reasons that you can believe. But we don't have proximity. And to me, proximity and the ability to know each other, communicate on a daily basis, often about important stuff like medical treatment plans, et cetera, but oftentimes not so much, just getting to know people are key. So the sheriff mentioned it. We're bringing that, it's a 16-man team, person team, mental health providers that are provided by the DHS. And we're putting them all together. They were fragmented, quite honestly, as well as they're doing different aspects of their job, but bringing them all together, they're pleased with that. And it's co-located, quite honestly, with the medical team. So we're all in the same administrative space right now. The clinical space remains segregated so that just to maximize the efficiency there. There's growing pains, of course, but those kind of opening the lines of communication, ease of work, focusing on the entire patient, the holistic patient, are all the reasons why we're going through it. So hopefully that answered the question.
Sean, I want to bounce back to you for a moment because while we're still talking about personnel, you had some approaches to how do you find people in the community, people like Christine. Of course, that was before you, but how do you find those people? Well,
Christine was kind of just before me because I worked with her where I came from. So she basically had a "don't you dare leave without me" conversation with me, and it happened. She wasn't in an ideal situation. The place we left was amazing when we left. But I know she didn't have a great relationship with her supervisor, and she was ripe for the picking. So we snagged her up, and I think she came up about 2 weeks after I did. But I think kind of what the sheriff was maybe alluding to earlier, I think there's some draw when it comes to just working for the office of sheriff. I think it's pretty cool. And our sheriff, when he swears people in, he swears civilians in. He said, you know, Florida statute says the sheriff doesn't get to do it all by himself. He has to appoint deputy sheriffs. And he says he can make an argument that any civilian at work or anybody who works for him is a deputy sheriff, whether sworn or civilian. And he does say it. He treats everybody. Our sheriff's great. She treats everybody the same. Doesn't matter if you're civilian or sworn. It's you have a role and you're vital to the success of the agency. So I think especially when we have a good agency culture and a good reputation, I think there's some natural recruitment that just comes with the office of sheriff, which is kind of cool. And I mean, in general, even if it's a county-run jail, I mean, getting to work in a place where you have badges and sometimes guns and tasers and stuff, it's kind of cool. I mean, I'm not saying the nurses are going to go and start tasing people because I know I end up having to maybe lock some of my nurses up, but I'm just kidding, Christine. But I think there's a natural recruitment factor there. But I think it was word of mouth, and there's some real opportunity in most states have, especially for sheriffs running the jail, have their state sheriff's association that could absolutely help. You know, just even if it's just, hey, do you know anybody? We have one remaining county in Florida that is run by a private vendor, meaning the Core Civic is running the jail to the county north of us. I mean, there's rumblings. There's a new sheriff up there. There's rumblings that they may take that jail as the sheriff's office. And those questions have already been posed. Do you know anybody who might want to be a jail administrator? Do you know anybody who might want to do what Christine does and help us during the transition if it came down to it? That word of mouth and those networking and the relationships are key to success. Like I said, there's a natural draw, I think, to working for a sheriff, but they're obviously having good networking, good relationships, especially with associations, could go a long way.
Thank you. Rick Bishop, can you unmute yourself?
Certainly. Good morning.
Yes, good morning. So Rick, you brought up, Sean, the state association. So Rick is the jail liaison for the Washington State Sheriffs and Police police association, whatever. Rick, you had some thoughts about the disadvantages of county employee. If you just want to say a word about that, and then I want to see if anybody kind of has some, how do you fix those?
Well, thanks. Didn't expect to come on, but thank you. I'm a recovering jail administrator. Been out for about 4 years. My phone rang right after I retired and came in with WASPIC. So I managed from public to private medical, and managing at that time, we had the due process. We had the discharge, and I was wondering if anyone had talked about or looked at the long amount of time it takes with a public employee, at least in the state of Washington and Oregon, to discharge someone or discipline someone, pre-investigation, post, and things like that. And I see the doctor shaking his head. So that was my question. Just one of the reasons we went private, and I, excuse me, was because they had a pool and they could bring people in quickly, and we didn't have that up and down. Because I remember as a sergeant calling people in the middle of the night, trying to get nurses in and trying to get medical people in. So just was asking that question and see if anyone had talked about it. And thanks for taking my question. Appreciate it.
Anybody? Jose, Sean, Dr. Malish, Christine, what thoughts? I mean, it's the.
So real quick, Dr. Stern, there was a story I can tell from, it's third hand, was the county we came from, Christine and I came from. When we left, it seemed like it was less than a year that they had gone private medical, but the sheriff down there did a real favor to a few of the nurses who were getting really close in the retirement system, and he was able to keep them on in the retirement system so they could finish up their minimum years before having to make a decision whether to go to the private company or find another Florida retirement system employer. I think he did that for 2 nurses. I think Christine would know better than me, but that was a good thing that he did for them, because that's the hard part. You have long-term, well-serving, tenured people that suddenly, most likely because of a financial decision or operation decision, they're not really in the mix of things. And if they leave and don't find a similar retirement system that lines up, then they could really, that's life altering for people. So that's a huge factor.
That's
Thanks,
another
Sean.
challenge as well. The challenge is when those rumblings start about either going to the sheriff's office, self-op, or going private, and the staff starts hearing those rumblings, they panic and they may leave. That's what happened with us when we took over from the private vendor. There was hardly any nurses that worked here because they knew that they lost the contract and they weren't going to have a job. So they're not going to wait for that to happen. Sometimes they up and leave. So that's a very good point. It's very challenging.
So that's a really, a good lesson learned. And Jose, I know you dealt with that a little bit. How did you deal with it?
Well, what I did, and again, as the sheriff and the authority here in my office, I'm very open about it and transparent. And so I wanted to not only communicate to the nursing staff, also to my staff, because those rumblings stress everyone out. And one of the things that I think we're still working on, but you think of a construction site or, this is coming. That's what I want. Everything I know, with the exception of obviously if it's something, a personnel matter or confidential, if the staff, they need to know what's going on because that stresses people out. And so you're asking specifically about the nurses. We've been very open about it. And, the vendor, like it or not, I mean, it's my office, my building. I'm going to share with folks, this is what's coming. Because if I tell my staff through the way things work, they're going to tell the nurses during med say, hey, did you hear? So either way, it's not a secret. We're being very open and transparent because, Sean mentioned it, you're dealing with people, people's careers, people's income, all of us pay for things and have to survive. And so me, Jose, as long as I'm the sheriff, I'm being very transparent and open with what I'm planning to do and how I'm doing it so that, it might be a little complicated for the vendor, But I
So-
don't want anyone to be surprised. I don't know if that answers your question, but that's
Well,
how.
it does. So, but I'm going to put you on the spot now relative to Christine's concern of, people starting to leave. What happened? How did that work for you? Where you told them early on in the process?
Yeah, because there was a lot of mixed information, right? So there was misinformation, bad information, and it was one of those, is it true? Yes, it's true. And obviously, once I hired Dr. Malish, you're not going to have two doctors in the building just because. And so it kind of made it, folks saw, okay, this is real. And so I think we're at a place where people are either going to, leave, or they're anxiously waiting to see when we start hiring, or people have to make their own decisions, right? And so I think again, Christine mentioned that we have a great benefits package with the county for retirement and leave and all that. A lot of the nurses, and Dr. Malish may know a little more if I misspeak, but I think they're using a lot of contracted nurses anyway, or agency nurses, temps and all that. And so yeah, I
So
think
has there been an exodus?
Dr. Malish, I don't think so. No.
No, I mean, there's my take on it. Well, two things. My take on this is just a level of professionalism, both from the vendor and from the staff here. And the sheriff and the deputy or the chief have done a great job, in my opinion, of communicating with the vendors' staff. And we can't offer them positions, one-for-one trade-offs. But I think at the basic level, and I've been a contractor and I've been a federal employee. And when you're a contractor, much of the time you're angling to figure out how you can become agency, or I'm saying federal, but a county employee because of the benefits. And so many of them, I think, are incentivized because that was sort of their end game anyway. And the benefits that have been described are very, very nice here in the county. So I think many of them, and we can't say, hey, we're gonna retain you after you leave, because they have to go through the hiring process, merit systems, selection, all like that. But it does gives them an advantage for sure, and a high likelihood of winning those positions. And so I think many of them are of the mindset that they have a very, very good chance of staying on, and for all the reasons that they're loyal to their mission, to their teammates, etc. I think they're wanting to continue with us. Had the vendor just dropped everybody and said, hey, we're done with this team, that would have been different. But there's been a level of professionalism, both from the sheriff's staff here, who have done a great job of communicating and saying, hey, these are the phases, this is what we're going to go through. We're moving away from the contractor, but that doesn't necessarily mean it's the end for you and our organization. I make that point. The second point I wanted to make was with hiring, these specialty providers potentially at a lower pay grade that they could make. There's plenty of people out there like me, for example. I mean, I've been in the Army for 30 years as a cardiologist. Had I wanted to make a ton of money, my motivation wasn't necessarily to make as much money as possible. And there's a lot of goodness. And I just want to bring up a quick anecdote from our hiring. One of the panel members, we're looking at HSA, says, man, that guy is really well qualified. I wonder if they're too qualified for the position. And I said, or are they too good for the position? I'm like, no, this position is actually very good. It might not pay that well, but it has all these benefits. It's got fixed hours. You know when you're going to be there. You know when you're going to leave. It offers this intellectual. All these things make the job more appealing than you might think. So there's a little bit of a self-esteem issue. But these jobs are not. Somebody mentioned it, but they have a lot of upside. I'll mention that. And then the other thing that was important for me, when you're doing the interviews, you're also pitching yourselves. And that's what the sheriff's department did well for me when I was interviewing. I interviewed with the key staff members, and I was just like, this looks like a great team to work with. Love the mission. These are great leaders. They're great people. I like their personalities. Their hearts are in the right places. They're getting after a challenging, complex mission. And I think that's sort of what we've been trying to do as we've hired these other specialty providers, is showing the goodness of all this. And also, it's a two-way audition, bring out the highlights and the greatness and the good things that are available, should you come on with the jail. So again, a long rambling answer. I'm not sure if I answered what the question was, but just some thoughts.
Thank you, Dr. Malish. Christine, I'm going to come back to you and switch topics here. I want to talk about policies. In other words, as you're transitioning, the most of the private vendors come with their own set of policies, and now you have to have your own policies. How do you do that transition?
Well, I think again, networking is your big thing. As I connect, we're always sharing policies on there, but you have other resources such as your accreditations like your NCCHC, your other local if it's sheriff run, your other local jails, and just networking to get ideas and bases for your own policies. That's what we did. I mean, we I kind of brought them with me, so we tweaked them. I mean, there was things that didn't happen here that happened in that community because it's different communities, but it gives you a basis for it. So just networking to make sure, and most policies are driven by not only community standards of care, but whatever your accrediting bodies are. So getting some of those involved, and I'm sure they're willing to help you, guide you as to what you need to have in place to insulate yourself from liability is what it really is.
Yeah. So you brought policies with you, and Dr. Malish, how are you? You're in the middle of the process, I'm thinking.
Yeah. So again, this has nothing to do with me, but the foresight of the Arlington County. The contract that was written with the vendor specifically talks about intellectual content policies, procedures, all of that. And the contract is written that all of that gets to continue with the county. So this happened before I ever got here. Now, how that will actually transition, I don't know, but it's in the contract that any intellectual property we can continue, that the vendor, as part of the contract, will release to us as long as we don't sell it to a third party or anything like that. So there was some incredible foresight in the writing of the contract. And again, that makes things easier for us because we can continue, just like these other things I mentioned before, these subcontracts, we can continue with what's in place using the policies, procedures, nursing protocols, all of that after the contractor leaves, until we have the center of gravity needed to kind of make those changes. But I think there's foresightedness in the writing of the contract with the vendor that puts us in an incredibly good place right now.
Yeah. So to kind of capture that, if you're not sure, if you're a jail that's not sure if you want to privatize right now, and you might go through another cycle or two of contracting, just like we talked about with the electronic health record, foreseeing that, like Dr. Malish was saying, foresee the policy thing and just write it in. Say, if and when you leave, we have the option of keeping your policies. And I also wanted to reiterate something that you guys brought up. So the NCCHC accreditation standards is a really good place to start, because most vendors' policies pretty much are based on those. Use that as a framework anyhow. So good. Last thing that on the list before we go to questions, or unless there's something else you guys, is let's talk about the bottom line cost. Christine, cost savings, not, it's the opposite of cost saving, was more expensive, less expensive. What happened to costs with the transition?
Well, a couple of things with cost, and President Kluznik could probably talk more in detail than me, but we are definitely doing it cheaper than Core Civic was, CCA was as a whole, because they ran the whole jail, so it wasn't just the medical aspect. But I've also had private medical vendors come in to give us proposals to see if they could perhaps, get a contract here. And the last one, I believe, we were over $1 million cheaper that we're doing it. So our dynamic is a little different. Our structure of budgetary constraints with the county and us, so there's not a whole lot of room for profit, and I think that's why. Our sheriff's office budget is basically staff salaries, the contractor, the lab that we send our labs to. It's very minimal, and supplies. Basically, staff is the biggest portion of it. So there's not a whole lot of room for profit for them, and I believe that's why.
Yeah, so in our county, the hospital budget belongs with the Board of County Commissioners. So basically, the sheriff's budget will pay for anything that happens inside the building or can happen inside the building. And anything that should happen outside the building, the county pays for separately. That includes, when it comes to our agreement, that includes dental. Dental comes here. And typically the dentist would be outside, but the county pays for the dentist in our building because it should be typically handled in the community. So we're probably an anomaly of the 67 counties in Florida, maybe the one north of us with CoreCivic still in place because we assumed a CoreCivic operation, basically. And that's something that we've just never fixed, and I don't want to fix because managing a hospital budget is a nightmare. And I don't want to have to deal with that, but we've been pretty lucky. So you want to just compare our operation in 2025 going into 26. We are $1 million ahead of, if the original contract were to get the baseline 3% increases every year from CoreCivic, then they'd still be $1 million more expensive than our operation. And we've increased staff. We've, like Christine said, we have practitioners on staff now. So we are able to control those costs.
Wegman and Aero Group.
Nick, could you please mute yourself?
I did.
Oh, thank you.
So we're able to control those costs, and Christine's done a great job of managing costs and being creative when it comes to, and having that ability to be creative, because sometimes like even our, so different topic, but our food budget. So a food vendor can't always get donations, but we have a sausage company across the street that has a contract with a local grocery store or local grocer that if their frozen meat is less than 20 degrees below zero, so it gets to 19 degrees below zero, that grocery store won't take that meat anymore. It's rock solid frozen. We'll take it, and I'll save money on the protein, right? So we get to save money that way, and we can be creative. Obviously, we're going to stay within a community standards of care, but we can be creative in managing our budget too.
Jose, is it too soon for you to know how costs are going to shake out?
Too soon, but I'll say this. I use a lot of examples. We've been eating out. And so now that we're cooking at home, we got to buy dishes and plates and all that. And so, it's a real conversation, though, with the community, with the powers that be, because that's what they care about. Jose, you have these grand ideas. What's it going to cost? I say it's going to save us money because, to my basic example, eating out is expensive because you're paying for someone else to do it. So that's my theory. I know it's very basic, but I foresee that we're going to save money. The other thing, Dr. Stern, I don't know if you're going to cover it really quickly. We talk a lot about how are we going to measure our success. And that's something that we talk about with Dr. Malish a lot. And he brought it up, actually. He's like, when are we going to, so we have different areas. And I don't know if you're ready for that or you want to talk about it or we're running out of time, but measuring success is something that we talk about a lot.
Well, I guess what I'll say about that is that you should be measuring success regardless of your model, whether you're public or private. You should be doing this, whatever you were doing before, you should have been measuring, I mean, other than like cost issues, but you should have been measuring your vendor. You should be measuring your vendor against certain performance standards. And you should continue to measure yourself against those same ones. So that is important. Is there, before we open for questions, there's anything else generally about the transition from private to public that Christine or Jose, Dr. Malish, President Kluznik, anything that we should cover, and then we'll go into questions?
I think you covered everything, Dr. Stern.
The profit piece, just to catch up on that for a moment. When you have a private vendor, they're a private company and they're supposed to make a profit. That's our model. That's capitalism. There's nothing wrong with it, but there is a profit margin. And I think, as Christine, you were mentioning, the sheriff's office doesn't have to make a profit. And we don't know exactly what that is. It's probably in the ballpark of about 10%. So now, if you're operating jail really inefficiently and you bring in a private vendor, you're gonna be more cost efficient. The vendor will bring that. On the other hand, if you have the capabilities of being a good leader and a good manager internally, then you should be able to do it for less money. But there's, as Sean said at the very beginning, there's no right answer here. We're just offering options. Sean, what do you think? Is it time to open it up?
Sure. Well, real quick, just make one more point. I was talking about the hospital budget being on the Board of County Commissioners side. So that doesn't mean Christine doesn't work her rear end off every single month trying to help them manage their costs, because they're still in our custody. We're sitting on the post. We actively try to manage through our practitioners, through our doctor, and relationships we have with the hospitals about, when they start asking about doing tests that I'm like, this makes absolutely no sense of what they're doing. That's why I was able to, I think, manage through that CCHP exam so smoothly. I won't say it's easy because it's tough, but I'm interested. I'm interested in what we do, and in being a jail administrator, I have to be interested in what medical's doing. Otherwise, I'm going to get sued. I'm going to get fired. It's going to happen. So, but Christine is not responsible for the county's budget in the hospital, but we try to manage the hospital post to the best of our ability to help save costs, because ultimately we're responsible for the taxpayers and it's their money. So we're going to protect it no matter who's responsible for it. Let's put it that way. So, but I saw that Fred Meyer came on with his camera, so I'm thinking he's got a question, and it's starting to scare me a little bit. So I'm going to mute.
No, nothing. First, just a comment. I want to thank the American Jail Association and certainly Dr. Stern for putting this out there. I can tell you, I'm all across the nation. I work in jails and prisons from Alaska to New Jersey. And I can tell you the one thing that right off the bat, this is a benefit of the engagement that Major Kluznik and Sheriff and Chiefs and Lieutenant Lehman, I see are on here, all those folks that are on the custody side that are engaged. That's the biggest thing that you can do to save yourself liability, improve care, and everything else. And that's why this is so great. I commend you all for stepping out on the skinny branch and getting engaged and trying to take these things in-house. I know it can be difficult. Every agency has a different setup, whether it's, Major Kluznik talking about how he has the involvement of the other local entities that are taking up a portion of it. Certainly, I do want to take a moment just to say there are brand new standards coming out by the National Commission on Correctional Healthcare. Anyone that's having issues with their own policies, things like that, I know it was mentioned, a lot of people will base their medical mental health policies right on those standards because it does give you that base. And like the doctor was saying, if you're coming from the outside, correctional healthcare is different than being out in private industry or out there in the public. It's a very, very different animal. There are some different requirements and specializations. So, I commend the engagement as well on the medical mental health side. Dr. Malish and the rest of the medical folks here, the fact that you are engaged at this level is truly commendable. And it makes a huge difference because I always like to say there's the 3 C's in corrections, right? There's care, collaboration, and costs. And certainly probably costs is number one on a lot of the government officials' minds, especially county commissions and things like that. But collaboration and care are intertwined so closely that a lot of the agencies that I'm in and that I have experience with, when they have a lot of in-custody deaths, when they have a lot of problems with chronic care, whether it's issues with dental, any myriad of the issues out there, a lot of it goes back to leadership. And the fact that you all are so engaged with one another is truly commendable. That interdisciplinary leadership is critical to mitigate your liability and provide effective care. So I did want to just give everybody a heads up. The new standards from the National Commission on Correctional Healthcare will be coming out in July. And then for those of you that are accredited by the NCCHC, those will become the official standard for the accreditation process as of January 1, 2026. If anyone is looking for key performance indicators, some of the really good ones, you're looking at your rates of suicide attempts, in custody deaths, your send outs to the ERs. your chronic care. And certainly the one that I think there is issues with from coast to coast, dental. That's one that I think kind of gets put to the wayside. We always think about medical and mental health, and certainly dental is a significant issue in a lot of facilities across the nation. So I just wanted to commend you all. And certainly if anyone has any questions, whether you're accredited or not, you can give us a call at the National Commission. We're happy to talk to folks, explain the process. Or if you have questions about standards, hey, why is this standard in process where it's at? We're happy to describe. And of course, we work with the American Jail Association a lot, and just love the engagement. And certainly I'll be very, very interested to see those key performance indicators, as well as the cost long-term if you end up saving money with it. In addition to if that care improves, if you do see a reduction in your send-outs to the ER, a reduction in deaths, hopefully that'll be the case. But just the mere fact that your leadership on the custody side is so engaged, it's going to make a huge difference, because there's always issue, whether it's transport issues, getting people to clinic, things like that. So just very thankful to the American Jail Association, certainly to you, Dr. Stern. NIC is another great resource, and anything that the National Commission can do to support your processes, we're here, and certainly willing to help out any way we can. So thank you very much.
Yeah, thanks, Fred. And Connie has put in the chat some of these resources: the Jail and Justice Support Center, the NCCHC Resources Center that Fred just spoke about, and our contact emails. So, Sean, we're back to questions.
Yep. Does anybody have any?
And I think people can they can unmute themselves, or do you have that control?
They can unmute.
Hey, Mark, I had one comment.
Hey, Susan.
Hey, Mark. I think the key performance indicators, of course, is really important, but what is just as important is the auditing of those. And I think one of the things that you've got to do is come up with some audit instruments, and then you have to have some credibility and integrity in the audit process. So I know one of the things that I did was I actually, in addition to the HSA, I had that was performing work. This was for a private vendor, but I also hired in somebody every quarter to audit my auditor, because sometimes people can get influence to provide certain results that may not be true. So I think the other part of it is, and of course, Dr. Bob Greifinger is the one that's really done a lot of the work on the auditing. So I would say, okay, key performance indicators, excellent, but you better be auditing those with credibly, and that what you're auditing actually means something. So that was just what I wanted to offer.
You know, that's really important. Even a more basic step before you get that, there are agencies that have key performance indicators, and they just don't get around to doing them. But so that's even more fundamental. But then, as Susan said, yeah, you got to believe the results, and the person who does it has to have a fiduciary responsibility to the jail commander. And then I love the idea of auditing the auditors to make sure that they're, and it may not even be intentional. It could just be unintentional bias. It could just be a matter of education. Sometimes you see things being audited and somebody gets credit for doing it just because they did it and they did it on time, but maybe they didn't do it properly, and that isn't quite meeting what you expected in the KPI, key performance indicator. Thanks, Susan. Others? While we're waiting, I will share something that Sean asked me to remember to share, which is a toolkit that just came out within the last few months that AJA had a role in supporting, which is really intended. One of Sean's point is we're not trying to sell un-privatization, pun unintended, but if you are continuing even temporarily to use a private vendor, this is a toolkit that has a model RFP in it that has all the elements of what you should be looking for when you privatize, when you have a vendor come in. If you continue privatization, has all the elements that we've talked about, for example, of continuation of policies and electronic health records, and personnel and the like. So you can either use the QR or the URL here. I'll leave that up for a moment. Other questions or thoughts?
I do have one question, and I apologize in advance. You don't have to share, but just in retrospect, because I know for us, if we wanted to bring our medical unit in-house and we proposed it in front of the county board, one of their biggest questions would be the financial guesstimate, right? In your transition and turnover here, are you finding that it's relatively the same financial amount than your contracted entity? Or are you finding it be more expensive or perhaps cheaper so far?
Christine, you want to start with that, and then Jose?
Well, ours was unique because, as I said, it wasn't just the medical aspect, but we're definitely, when looking at the medical aspects of private entity looking at us, we were $1 million cheap. Doing
Jose?
one. We had 2 vendors, one never even got back to us.
So we started off with the number that we currently have, obviously, for the medical contract. And so we took that and we did our own semi breakdown, and we're still in the beginning phase. So I don't think we can say, confidently one way or the other, but it's a $5.5 million medical contract that we have currently. And so taking that number, yeah.
And Kathleen, where are you?
I'm at Kane County, so we're like an hour away from Chicago in Illinois. And we currently have a contracted vendor. Our contract is 4.5 million, and my partner and I are actually doing that exact same financial breakdown with each salary position, how much the pharmacies costed over the last couple of years. And at this moment, it seems to be only like $500,000 more expensive than our contract. And in my head, I just feel like that's not possible. I feel like that's way too good to be true. Of course, like you're always going to have that outlier situation of if, God forbid, some detainee has some serious medical issue that will throw off your whole budget. But that's why I was just inquiring to see if that was something that you had found too.
What is your ADP, Kathleen?
Around 340, but similar in size. We can house up to 680, I believe. So we have similar in size.
If I could just add some additional information. So I think everybody will know that there's going to be an upfront cost to the transition. But then there's downstream benefits that have already been mentioned. And that is, like for me, I'm a county employee and I'll be working within a system of other county employees. And so the way I look at it is now I'm just a teammate with teammates that I have to support on either side of me. And so those teammates include EMS and ambulance transfers. It includes our county hospital, and all of these teammates are impacted right now by a profit-seeking, risk-averse vendor. And I'm not trying to cast judgment on them one way or another. It is what it is. But they're very sensitive in terms of using these other resources. So they will use ambulances for transport to the hospital, and then there's not a lot of feedback whereby which they learn. And again, I don't mean to make any sort of comments, but on the vendor. At the end of the day, though, I understand that this jail is managing a population of people that, for the moment, are within the jail. They could otherwise be out on the streets and using other resources. But as a community, we all have to, be resource conscious. So one of the things we'll definitely, and I'm working with the EMS system here. There's a lot of unnecessary work that happens when you don't think of yourself as a steward of these county resources. And again, I'm just mentioning the hospitals, EMS, laboratory services, all of this. There's costs to it that if you don't have this continuous quality improvement process to learn how to understand risk and lower the risk, that risk is going to spill over into cost, and it might not show up on your budget sheet but it isn't a taxpayer dollar.
Other questions? Thanks, Richard.
I have a question about hiring for your providers and your nurse practitioners. How important is it for them to have correctional experience? Because that's one of the things that we have trouble with, even with our contracted provider, is finding people who have correctional experience. And if we look at moving on, even 2 of the ones we have, we probably would not be interested in keeping.
I'm going to take the first stab at this answer and then see if anybody has anything to add. You can learn corrections. You can't learn how to be a good practitioner. I mean, you can, but I can teach somebody what they need to know about in corrections in a few days or a couple of weeks. I start with them reading the NCCHC standards. And I mean, there is something to it. There is a profession. There even is a subspecialty now. But having a good, solid, for example, nurse who has experience, broad experience in medical surgery, or having a physician like Dr. Malish, that's much more important. If I can get somebody who also has correctional experience, that's icing on the cake, but it's not where I start. So, Dr. Malish, Jose, Steen?
I have another suggestion. I had a psychiatric nurse practitioner, Columbia University, Ivy League school, best in the business. She was getting ready to retire, and there's not a whole lot of psychiatric nurse practitioners in our community. So I was like, how are we going to replace her? What are we going to do? How are we going to afford it? Because they make more than family nurse practitioners. And we do students here for nursing. We do local schools. Well, I got a phone call from this woman asking if she could do an internship here as a psychiatric nurse practitioner. Been a nurse for many, many, many years, RN, and she was getting her psychiatric nurse practitioner. So she worked here, did her internship under the psychiatric nurse practitioner for a year, and then transitioned to her psychiatric nurse practitioner while the psychiatric nurse practitioner stepped back and took the role on as an RN to assist with that transition. So there's other things, and I'm not saying everybody should be brand new, but she's phenomenal. And she had a psych background as an RN to begin with. So there's other things that you can look at, and looking at your local schools for any kind of help, not just nurse practitioners, is a good avenue to have to recruit people and have them try it and see if you like them and they like it.
Yeah,
Richard?
we have, sorry, real quick, we have relationships with 6, I think it's 6 total nursing schools in our area that in any day of the week, 2 of them could be here. And I'm like, what color scrubs are they wearing? Where are they from? What school? I can't keep up. But it exposes them to the jail. It exposes them to that door slamming behind them, walking in, and the culture. And a lot of the time, if, like I said earlier, if your culture is good, it's going to be a natural draw and people are going to want to come there. So if you be creative with those kind of recruitment tools, invite the nursing students in, the schools in. And we lucked out with Lucy, I'll say her name. She's amazing. Our psychiatric APRN is amazing. She did get to train under one of the best that I've ever met. So we did absolutely luck out there. Is it scary? Is it daunting? Is it like super stressful to try to recruit a team? Yeah, but I bet you it'll happen, especially if you know that you're working in a culture that's positive and a good reputation in the community. It'll happen.
Richard or Jose, did you have anything on the need for, really Joanne's point about the need for correctional experience?
I'll let the sheriff answer, but it's a factor, but I wouldn't say it's weighted any more heavily than anything else. You know, we've just completed one round of interviews, and a lot of, you know, what you look for is a good teammate who's going to be a good fit for your team. Their background is important, their level of expertise, but it's just one factor of many. So I agree with you, Dr. Stern. Is that person, are they wowing you for all the other reasons? And if they are, then they're probably the right one. I don't know, Sheriff, if you have anything else.
I don't have too much to add. I'm just looking for good people. People, like Sean said, they want to make a difference and that are up for the challenge. I think we see that even in our profession for jailers and deputy sheriffs. You know, I came from the time of when everyone was leaving the military and jumping into law enforcement. Now we're hiring folks that never thought they would be working in corrections, and they actually do a decent job with guidance, with coaching, with mentoring. So, yeah.
Thank you, guys. Well, we're at time. This was meant to be a first time kind of exploration, like Sean said. There were a couple of jails who had questions. We thought, gee, it would be a great idea to just share ideas. We can do it again. There are resources that are on the chat if anybody wants to reach out to any of us. And Sean, I will let you take us out, please.
Awesome. Well, thank you everybody for participating. I want to encourage you, remember that this conversation started on iConnect. iConnect is a great place to ask these questions and then follow up. So if you want to continue the conversation, there's plenty of opportunity there. And if you ever need a specific topic addressed and you think the American Jail Association can help you in any way, feel free to reach out. All of our contact information is in that chat. Send me an email. I'm happy to respond to email. Fred will get emails from me at 11:30 at night, 2 o'clock in the morning. And he never knows what time zone he's in, so it doesn't matter. But just realize we're here for you. We're here for the membership. And never hesitate to reach out. Dr. Stern, good job steering this ship. I appreciate it. Thank you very much.
Thank you, guys. Everybody have a good rest of your day. Bye now.